Good morning, all, and thank you for giving me the opportunity to talk about thromboembolic complications of pregnancy. This is a common clinical scenario in our lives, so I thought of refreshing our memories with it. Let's start with the first slide. As we all know, it's a leading non obstetrical cause of maternal mortality, and the incidence is between 0.05 to 0.3%. The risk of thromboembolism during pregnancy and postpartum period is 10 times greater than that of a non-pregnant patient, where the mortality rate is whoopingly high of 15%, where the pregnancy results in a 5 to 6 time folds of increase in relative risk of venous thromboembolism. So what is the epidemiology? So every 1 in 100,000 women of childbearing age, that is the kind of incidence, and 1 in every 1,000 pregnancy in women which are under the age of 35, these thromboembolism episodes are seen. And every 4 in 1,000 pregnancy in women when it is over the age of 35 years. If treated with anticoagulation, embolization will occur in only 4.5%, which are the main contributors to the venous thromboembolism mortality, which becomes the leading direct cause of maternal mortality in United Kingdom, being responsible for a third of maternal deaths. So the risk per day is actually greatest in the weeks following the delivery, which is approximately 10 to 20% of all the venous thromboembolisms or pulmonary embolisms, wherein 62% of women with fatal venous thromboembolisms die in the first trimester, which is 71% of all the postpartum deaths from the venous thromboembolism that occurs following vaginal delivery. Whereas in 10% of postpartum deaths from the venous thromboembolism occurs following an operative or interventional vaginal delivery. So the presentation is similar to a non-pregnant patients with a deep venous thrombosis or pulmonary embolism. The pulmonary thromboembolism occurs most often secondary to a deep venous thrombosis, which occurs after a superficial vein thrombosis or a puerperal septic vein thrombosis or puerperal ovarian vein thrombosis. The deep vein thrombosis with an incidence of 0.02% to 0.36%. Most of them occur between 15 to 20 weeks of gestation. So let's talk about superficial vein thrombosis. The incidence that has been seen with the superficial vein thrombosis is 0.15% and can occur during the antepartum period incidence and increases eightfold into postpartum period. Whereas in puerperal ovarian vein thrombosis, the incidence is little less, which is 0.025%. And in septic pelvic vein thrombosis, the incidence has been seen to be 0.1%. So why should we worry? So around 13 to 24% of pregnant patients with an untreated deep vein thrombosis experience pulmonary embolism. And the mortality of pulmonary embolism is between 12 to 15%. So the treatment decreases the incidence of the pulmonary embolism to 0.7 to 4.5%, and overall mortality is reduced by 0.7%. Whereas in untreated septic pelvic vein thrombosis has a pulmonary embolization incidence of 33%. In spite of great advancement in controlling the maternal mortality, the pulmonary thromboembolism accounts directly for 12 to 25% of all the maternal deaths. So let's talk about the etiology or causes. That includes increased venous stasis, hypercoagulable states of pregnancy, vascular injuries associated with vaginal or cesarean deliveries, obstetric conditions, and coincidental risk factors. So let's talk about one by one. Venous stasis, the compression of the inferior vena cava by the gravid uterus which increasingly becomes an abdominal organ as opposed to its original pelvic organ deposition. This leads to a venous stasis distal to the compression in the pelvis and lower extremities. And gravid uterus impairs the velocity of venous flow from the lower extremities, leading to DVT. The other state is hypercoagulability. As we all know, pregnancy is a hypercoagulable state. So, in pregnancy, it is due to the enhanced platelet turnover, coagulation, and fibrinolysis, further enhanced during parturition. It increases in concentration of coagulation factors, particularly factor 1, 5, 7, 8, 10, and 12. The other causes includes thrombin generation that increases during pregnancy, and pregnancy represents a state of accelerated but compensated intravascular coagulation, and the coagulation activity is increased relative to the fibrinolytic activity, leading to hypercoagulable state. Vascular trauma occurs during vaginal delivery and placental separation. This leads to a series of physiological changes that further accelerates the coagulation. In the cesarean section, it increases the risk of deep vein thrombosis and pulmonary embolism by eightfold over the vaginal delivery. So, what could be the risk factors? Hereditary, or it can be acquired. 80% of patients at least has one risk factor. Antenatal period is known to be a weak risk factor, whereas postpartum period is a moderate risk factor, including obstetrics and other risk factors. Now let's talk about inherited risk factors. It includes factor 5 latent mutations, which is the most common, followed by prothrombin mutations, antithrombin 3 deficiencies, protein C and protein S deficiencies, and hyperhomocystinemia and dysfibrinogenemia, and disorders of plasminogen and plasminogen activation, and if somebody has a strong family history. Let's talk about the acquired risk factors. It includes obesity, immobilization of more than 4 days, that is more than 4 days of bed rest, previous thrombotic event, trauma, inflammatory disorders such as inflammatory bowel disease, cancer, estrogen therapy, including contraception and hormone replacement therapy, sepsis, including urinary tract infections, gross varicose veins, antiphospholipid syndrome, nephrotic syndrome, paroxysmal nocturnal hemoglobinuria, stroke, polycythemia vera, sickle cell disease, and long haul travels. Other pregnancy related risk factors includes venous stasis, advanced maternal age, multiparity, gestation of less than 36 weeks, instrument assisted or cesarean delivery, hemorrhage, preeclampsia, and prolonged labor. Let's see what is the pathophysiology. The manifestation and prognosis of the pulmonary thromboembolism depends on several factors, including the site and size of the emboli, concurrent cardiopulmonary function, rate of clot fragmentation and lysis, and presence or absence of source for recurrent emboli. Let's see what are the symptoms we get during DVT. It includes leg pain and discomfort, swelling, tenderness, edema, increased temperature, and raised white cell count. It can also present with abdominal pain. These symptoms may be found in normal pregnancies also. If a person is completely asymptomatic with a retrospective diagnosis being made following a pulmonary embolism can also happen. Deep vein thrombosis is the most commonly manifest as pain and swelling, and the physical exam may reveal tenderness, a difference in leg circumference, redness, and a positive Hoffman sign. So, what investigation and diagnosis we need? Treatment with low molecular weight heparin should be started until the diagnosis is excluded by the objective testing, unless treatment is strongly contraindicated. Compression ultrasonography or pulse Doppler ultrasound is the diagnostic study of the choice in the cases of suspected deep vein thrombosis. The sensitivity is 91% and the specificity is 99%. When clinical findings are inconsistent with the Doppler studies, venography may be necessary. Let's talk about impedance plethysmography, which is not commonly used these days, only to be used in advanced cases. But I thought it is important to have a idea about it, which one of us don't have. So it is an alternative technique for a deep vein thrombosis diagnosis. Venous return in the lower extremity is occluded by an inflation of a thigh cuff, and then the cuff is released, resulting in a decrease in cuff blood volume. Any obstruction of the paroxysmal vein diminishes the volume change, which is detected by measuring changes in the electrical resistance, which is the impedance, over the cuff. If there is a clinical suspicion of a deep vein thrombosis, arrange an urgent compression duplex ultrasound scan. If this is negative and your suspicion is low, discontinue the treatment. If it is negative but your suspicion is high, repeat the scan or order an alternative imaging modality. 1 week later, while keeping the patient anticoagulated. If this is negative, then discontinue the anticoagulation. If you suspect an iliac vein thrombosis, the patient may present with back pain and swelling of the entire limb. Then go for a magnetic resonance venography or conventional contrast venography may be considered. So venography is an invasive procedure and contrast material can cause chemical phlebitis. Venography is useful when the results of other studies are equivocal. So it is not the first modality. So what are the symptoms of pulmonary embolism that we should look for? It includes dyspnea, pleuritic chest pain, hemoptysis, faintness, collapse, tachypnea, raised JVP, and ECG may show tachycardia, right bundle branch block, or S1Q3T3. And ABG shows a respiratory alkalosis and hypoxemia, and there may also be symptoms or signs of deep vein thrombosis. Pulmonary embolism is an extensive direct occlusion of the pulmonary vasculature, whereas severe pulmonary hypertension and right ventricular overload and failure can happen, leading to cardiopulmonary decompensation and ultimately leading to respiratory failure. Disruption of normal capillary integrity and aggressive intravenous volume resuscitations increases the hydrostatic pressure and leading to pulmonary edema and respiratory failure. So the clinical findings in pulmonary embolism, tachypnea is one of the most common clinical finding that comes, which is around 89%. And the least I think is high temperature, which is more than 37. Tachycardia is something that is very common in our clinical practice. So what investigations and diagnosis we should be doing? ECG is an abnormal in around 90% of cases. Tachycardia is the most common abnormality, and non-specific T-wave inversions occurs in 40%, whereas right axis shift with a strain pattern occurs with a large embolisms. P pulmonale and supraventricular arrhythmias may also occur. In the arterial blood gases, we may see a pulmonary embolism is unlikely with a PaO2 of more than 80% on room air. However, in 11.5% of patients with pulmonary embolism, the PaO2 value had been seen between 80 to 90%. So it is not very diagnostic. Coagulation studies, if a family history is repeated and it is present, then antithrombin 3 and protein C levels should be done. Invasive hemodynamic monitoring includes normal to low pulmonary artery obstructive pressures, which increases the PA pressures, which is less than 35 and increased more than 8 millimeters of mercury in CVP, and calculated PVR or pulmonary vascular resistance may be about 2.5 times the normal values. Technetium lung scanning. The perfusion scan is performed first and the normal scan excludes pulmonary embolism. If the perfusion scan is abnormal, a ventilation scan is completed. Matching ventilation perfusion defects are not suggestive of embolism. Almost all patients with pulmonary embolisms have an abnormal VQ scans results. Unfortunately, most patients without an emboli also have an abnormal results. So the sensitivity is 98%, but the specificity is very low of a technetium lung scan, which is 10%, when a clinical suspicion does not correlate with the results of lung scanning. Can we do any blood test? So D-dimer is an unreliable test to carry out in these patients. In pregnancy, it can be elevated because of physiological changes in the coagulation system, and levels become abnormal at term and in the postnatal period in most healthy pregnant women. So full blood count, coagulation screen, urea, electrolytes, and liver function test before anticoagulation therapy is recommended. There is a controversy surrounding the performance of a thrombophilia screen. It will not affect the immediate management of the patient, and results are distorted by the pregnant state and by the presence of a thrombus. However, it can provide information that can influence the duration and intensity of anticoagulation. So, the life-threatening pulmonary embolism management and outcomes, this is what we are going to discuss now. Nearly 10% of patients die in the first hour. Collapsed, shocked patients need to be managed, and we need to follow the ACLS protocols and cardiac resuscitation. Long-term survival depends upon rapid diagnosis and institution therapy. Adequate maternal and fetal oxygenation should be given. Support of maternal circulation, including uteroplacental perfusion, should be done. Immediate anticoagulation or venous interruption to prevent recurrence of lethal pulmonary embolism should be attempted. An urgent portable echocardiogram or a CT pulmonary angiogram within 1 hour of the presentation should be arranged. If massive pulmonary thromboembolism is confirmed immediately, we should thrombolize the patient. Urokinase and streptokinase can be used. Urokinase therapy is started at 4,400 international unit per kg, followed by 4,400 international units per kg per hour infusion to be given. Thrombin time is a sensitive indicator to follow the thrombolytic therapy. The thrombin time should never be greater than 5 times the normal value. We can also use intravenous unfractionated heparin, which is preferred treatment. Surgical embolectomy is an extreme measure if all the above measures fails. Let's talk about preventing and initiating and maintaining the therapy for the deep vein thrombosis in pregnancy. According to the American College of Obstetric and Gynecology, the recommendation includes like this. If a clinical situation suggests that you have a varicose veins, anticoagulation regime is not required. If the clinical situation says that you have superficial thrombophlebitis, again the anticoagulation is not recommended. But in a hypercoagulable state, the therapeutic dose of anticoagulation to be started. If we have a previous history of deep vein thrombosis or pulmonary embolism, the clinical situation including post-trauma, it is not required. If oral contraceptives are being used, therapeutic regime of anticoagulation should be given. If a person have antiphospholipid antibody syndrome, then therapeutic or prophylactic doses has to be started. If it is an unexplained previous DVT episode, then the therapeutic dose of Clexane or unfractionated heparin should be started. If there is a previous episode of DVT and it is occurring again and again in life, again it becomes a condition where we have to give the therapeutic dose of the anticoagulation. If we have DVT, definitely anticoagulation regime, we have to start with prophylactic doses. If in prior pregnancy, begin in the early pregnancy. If you have a pulmonary embolism in previous pregnancy, prophylactic or therapeutic doses can be started. So dehydration and immobilization of the patients antenatally during labor and postpartum should be avoided. If any risk factors like prophylaxis, this should be initiated as early in the pregnancy as possible. Postpartum prophylaxis should be commenced as soon as the delivery and is practically possible. If the patient is over 35 years of age and has a BMI of over 30 or a body weight of over 90 kg, prophylaxis is almost mandatory, especially in immediate postpartum period. Leg elevation and graduated elastic compression stockings applied to the reduced edema can help. Mobilization with graduated elastic compression stocking should be encouraged. So, what drugs to be used? Warfarin is the treatment option in postnatal patients. Avoid antenatally because warfarin has a teratogenic effect and can also cause placental abruption and fetal oblique neonatal hemorrhage. Stop or replace the heparin before the 7th week of conception. Temporary cable filters can be used if warfarin is contraindicated. Surgical embolectomy and other thrombus fragmentation strategies, invasive procedures can also be done. Drug choices includes unfractionated heparin and low molecular weight heparin. So unfractionated heparin can be given in the form of intravenous or subcutaneous form, or it can be given as subcutaneous solely. A mini dose of unfractionated regime and moderate dose of unfractionated regime has been recommended, and adjusted dose of unfractionated regime has also been recommended. So talking about unfractionated regime intravenous, loading dose will be 5000 international unit or 80 units per kg, followed by a continuous infusion of 15 to 20 international unit per kg per hour. APTT of 1.5 to 2.5 times should be kept during the infusion state. Corresponds to a circulating heparin level of 0.3 unit per ml, whereas an anti-factor 10A turf levels of 0.7 units per ml should be kept. Unfractionated heparin of 5000 units subcutaneously can be used as a mini dose regime, which is every 12 hours. If it comes to moderate dose regime, I have forgotten to write, but moderate dose is 7.5 thousand unit when compared to the mini dose, which is 5000. So unfractionated heparin can be given subcutaneously every 12 hours and the dose is 7500, and dose adjusted target of an anti-10A level of 0.1 to 0.3 units per ml should be kept. So subcutaneous unfractionated heparin adjusted dose regime includes unfractionated heparin subcutaneously every 12 hours, and the dose should be adjusted target a mid-interval APTT into a therapeutic range. So unfractionated heparin and why we need to monitor. If an unfractionated heparin is used, the monitor platelet count at least every other day for the first 14 days or until treatment is stopped. Seek a specialist advice if the patient develops heparin-induced thrombocytopenia or a heparin allergy and requires a continuous anticoagulation therapy. She should be managed with an heparinoid, danaparinoid sodium, or fundaparinox under specialist supervision if a person develops heparin-induced thrombocytopenia. Talking about low molecular weight heparin, which is our best friend, and we all are very comfortable with it. It is more effective. It has lower mortality. It has a fewer hemorrhagic complications and greater antithrombotic activity than anticoagulation activity. And APTT is unaffected by this drug. What about the prophylactic doses of low molecular weight heparin regime? So enoxaparin of 40 milligram once daily or 30 milligram twice, or 1 mg, which is equivalent to 100 units, and a peak anti-factor 10A activity occurs within 3 to 5 hours of an administration of 50% activity, which disappears within 6 hours of stopping the drug. Therapeutic anticoagulation like enoxaparin uses doses is between 30 to 60 mg twice daily if it is therapeutic. And the other enoxaparin related injections or drugs that we can use is tenazepam and dalteparin. Now talking about weight adjusted dose for the low molecular weight regime, enoxaparin of 100 units per kg twice daily of 1 mg per kg or 1.5 mg per kg once daily can be used, and thromboprophylaxis needs 2500 to 5000 units once daily or twice daily doses, and dalteparin will be 100 units per kg every 12 hours, or tenzaparin will be 175 units per kg once daily. And the maintenance therapy includes the low molecular weight, which are the preferred drugs. Routine platelet counts are not required. Anti-10A levels will only need to be monitored where there are extremes of weight, which is less than 50 kg or more than 90 kgs. So during labor, heparin is discontinued during the labor, and if APTT is abnormal and there is a risk of bleeding, incremental doses of protamine sulfate can be given. Planned elective induction of labor or cesarean section at least 12 hours after the prophylactic dose of low molecular weight heparin or 24 hours after the therapeutic dose of low molecular weight heparin should be practiced. Manage with intravenous unfractionated heparin throughout this time. Regional anesthesia or analgesic techniques should not be undertaken until at least 24 hours after the last dose of therapeutic low molecular weight heparin. In postpartum period, heparin treatment or warfarin can be given. Warfarin to be avoided until at least day 3 of postpartum. Aim for an INR between 2 and 3. Continue heparin treatment until there have been 2 successive readings of an INR of more than 2. Detectable in breast milk. All are safe for use during breastfeeding because warfarin metabolizes are inactive and heparin is not absorbed through the gastrointestinal tract. Stopping the treatment at least 6 to 12 weeks postpartum or until at least 3 months of therapy have been completed. Assess for the presence of ongoing risk factors for a venous thromboembolism prior to making the decision to stop the anticoagulation therapy. Thank you.